My name is QAYS ALHORANI. I am a PhD candidate at Faculty of Health Sciences, UQAM University. It is our pleasure today to present our topic under the title of Local Diagnostic Reference Level for Whole Body FDG PET-CT Examination for Adult Oncology Patients. As we know, PET-CT scanner providing a superior anatomical and functional diagnostic information in a single scan, aiding to detect several types of tumors, cardiac and neurological diseases. But we need to keep in our mind when we are dealing with the PET-CT that the PET-CT has a two components. As a result, we have a double dose given to the patient during the scanning of the PET-CT. Now it is the necessity of studying the potential radiation exposure from the PET-CT and determine the doses given to the patient from the two components of the machine, which continues to increase compared to the other diagnostic modality. Also, we need to keep in our mind that when we are dealing with the PET-CT for oncology patients, we need to apply the justification, optimization, and ALHORANI principle. To start defining the DRL, it is important to look for the ICRP report 2017. In their report number 135, they define the DRL as a diagnostic reference levels, which is a term used to aid in optimization of protection. To establish a DRL for any modality, we need to look for those quantities for a defined type of equipment, for typical examinations, for a group of patients. The background of our study, we notice that there is a large variation in DRL values locally, nationally, and internationally, which was associated mainly, according to many authors, to the acquisition protocols. Why we need to establish local DRLs in Jordan? According to the recommendation from the IEA, in their report to the Energy of Minerals Regulatory Commission in Jordan in 2017, they recommend that Jordan should establish their own DRLs, which is not yet. The objective of this study was to establish a local DRL for whole body FDG PET-CT scan in one of the major cancer centers, which is King Hussein Cancer Center. The methods that we are following in this study was divided into three phases. Phase one, to prepare a questionnaire booklet, and followed by a data collection, and followed by a data analysis and establishing local DRL. The data collection was divided into data related to dose, to patient, to technical parameters, and machine-related data. The approach that we followed in this study is a prospective non-weight restricted approach over the 3 months period. And also the local DRL was based on the 50th percentile according to the recommendation of the ICRP in their report 155, 2017, to calculate the administered activity given to the patients separately from the CT dose volume or CTDI volume and the dose length product from the CT part. We start applying for ethical approval from UQAM, followed by the Cancer Center. We gain the ethical approval that was followed by the data collection by the clinical investigator from the hospital, and then the data collected by the researcher. For our sample was the adult oncology patient for FDG whole body PET-CT, and we followed the non-weight restricted method, and the sample was 100 patients. Looking to the sample, we have the 42 female and male 58. The mean age was around 51, the weight 77 kilogram, and the height was 165 centimeter with a BMI 28. For the looking to the values, and we are focusing here for the mean, median, minimum, maximum. If we are looking to the administered activity given to the patients, the mean was 235, the median 223 megabecquerel. The CTDI volume was 3.8 as a median, and the DLP was 517.2 milligray centimeter. If we are establishing the DRL as a local DRL, which is proposed by this study, we are following the recommendation of the ICRP by calculating the 50th percentile of the activities given to the CTDI volume and the DLP. And according to these results, we are looking for the activity as 223 megabecquerel, the CTDI volume 3.8, and the DLP 517. By comparing our results with other type of studies in different countries. We have chosen Greece, for example, from Europe, Korea from Asia, and USA from America. We will figure out that our administrative activity in our center was the lowest, and the same as the same case was for the CTDI volume, but for the DLP it was more than Greece and less than Korea. The reason why the activity, why the activity is less, because we are following a low value of megabecquerel per kg compared to the other studies. As we can see that the activity that we are using in our center is around 3 megabecquerel per kg, while other studies, for example, in US, because they have their own guidelines, they are using 4.3, in Greece 4.8, and Korea 5.8. Even though the reported CDI volume was lower than the published identified data, that could be resulted from using low CT protocol parameters like MAS. The TLP was higher than the reported Greece median values. That was mainly due to the large scan length. In conclusion, the local DRL value for the whole body FDG was established at the King Hussein Cancer Center. Also, there is a need to study and optimize the CT protocol considering the patient body habitus and some CT scan parameters, for example, the scan length. The details of the PET CT scanner technology and PET CT acquisition protocol should be gathered for participating centers to establish the DRL, and this enable identification variation in radiation doses. And lastly, upon recording scan duration, for example, the megabecquerel per kg, administered activity, and CT acquisition parameters, all that can aid to underpin the DRL methods and a defined variation between radiation doses among participating PET CT centers. Those are our references. Thank you.